Chris Myers, the Managing Director of the Capitol Hill Campus Program. We're always glad that you can join us for our educational programs on the Hill. For those of you who are here for your first time, Mercatus and the Capitol Campus Program to bridge the gap between academics and policymakers so that you guys have the best information that's coming out of some of the best scholars in the university sector. You're kept abreast and up to date of all the newest information that you can. Today we are happy to be joined by David Hyman. He's the Richard and Mary Corbin Professor of Law and Professor of Medicine at the University of Illinois. He directs the EPSI program for Health Law and Policy. He focuses on research and writing on regulation and financing of healthcare, and so he teaches on regulation, civil procedure, insurance law, tax policy, and a number of issues. So, I did want to make two quick program notes. If you could see the Mercatus on Policy series promo that we have on pandemic flu. It's kind of based on a paper that our General Director, Tyler Allen, wrote a couple of years ago, I think 2005, on the avian flu. So if you want to review that, then go to the Mercatus website at www.mercatus.org and find that information out as to the full paper that he had done. It's got a lot of applicable stuff that you guys are looking at, the decision that you're having to make right now in dealing with the current swine flu problem. Also, if you could remember to fill out those blue survey forms for us, we greatly appreciate your feedback, and it helps us to maintain the quality of the programs that we're providing for you. So today, if we can all join me and join me in welcoming Dr. Hyman.
Thank you, Chris. Chris is actually leaving program operations to take over development for the Mercatus Center, but I've had a lot of fun working with him on these programs over the years. So I'm going to talk about 5 myths of American healthcare, or as the paper is somewhat slightly less tangential entitled, things people know that aren't so. Okay, and so I'm going to show you some data on these things as we go along. If you have questions about the data as we go, feel free to raise your hand and we can talk about it. The paper itself is posted on a site called SSRN, the Social Sciences Research Network, and I'm going to ask Chris to send people the link to the paper so that you can download it yourself and see the underlying sources. The myths of American healthcare that various people believe to varying degrees. I don't want to suggest that everybody in the room is mistaken on any or all of these necessarily, but lots of people nonetheless believe them to be so, even though they're not actually true. And you can sort of see it here. Employers pay for health insurance for their employees. There are 46 million uninsured Americans. Universal coverage means everyone will have access to high-quality care. It will solve the cost problems of American healthcare, and then we have the 37th best healthcare system in the world. And so what I want to do over the course of the time that we have is sort of walk you through some of the data on each of these and basically point out ways in which the matters are much more complicated than these simple statements might suggest. Some of them are flatly wrong, some of them are wrong to varying degrees, and the data gives you a slightly different take on things than a statement might suggest. So let me just start with a couple of take-home messages independent of the data points that I'm going to make. The first problem is that there are actually serious problems with the U.S. healthcare system on both the financing and the delivery side. And it's useful to think about these separately. They're obviously connected, but they're different, separate, serious problems on each side of the market. Okay? And nothing that I'm going to say today should lead you to a conclusion other than that. The second point, which I think is more salient for the discussion that's going on in Washington now, is fixing one side of the market doesn't really do very much to fix the problems on the other side of the market. So you shouldn't just assume we're done, we can now move on to everything else by having addressed either the financing side or the delivery side. There are going to be spillover impacts from what you do on one side of the market to the other side of the market, but you shouldn't assume that you solve the problems by just focusing on one of them. And some of the fixes on one side of the market may make problems on the other side of the market actually worse. The third important point is that we spend a lot of money on our healthcare system, and we don't really get consistent high quality or particularly good value out of it. Okay, and that's true of both the financing and the delivery side, but it's more true of the delivery side of the financing side. And then the last point I like to remind people of: every president, basically since Teddy Roosevelt, has taken a whack at some aspect of healthcare reform. Healthcare reform is sort of emerges and disappears from the national agenda. It's constantly on the state agenda. The reason for that is if it were easy to fix, we'd have done it already. And I have to talk about medical malpractice, which is the other area that I work instead of this. So let me focus first on the first myth of American healthcare, that employers pay for health insurance. EBC, or employment-based coverage, is a dominant reality of American healthcare. Unlike most other countries, we rely to a very substantial extent on employers to provide coverage for their employees. So about 60% of the population has employment-based coverage. That number has been as low as 3% at the dawn of the employment-based coverage system, which was immediately post-World War II. It's been as high as about 70% of the population. Employment-based coverage is not going to get you to universal coverage. You can expect that it will do that. It's sort of eroded some over the course of the last several decades. It was as high as sort of 68, 69% of the population. And it's trended down, and the trend down gets steeper in a recession, it shallows, and sometimes reverses when times are better. But right now we're at about 59 to 60%. And everybody can sort of, people can read that, right? I don't want to go through all of the bullets. Everybody in the back can read. The other reason to be interested and concerned about who pays for employment-based coverage is because it's employment-based, if you lose your job, you generally lose your coverage. Now, COBRA creates the possibility of extending employment-based coverage, but requires the individuals to pay the full price. Historically, that meant most of those people didn't get it. It remains to be seen how the budget stimulus package provisions that basically paid for a substantial percentage of the difference are going to end up working out. But the conventional figures is every 1% increase in the unemployment rate results in a sort of 1 million increase in the number of people covered under Medicaid, and 1 million plus a little bit increase in the number of people who are uninsured. And our national unemployment rate through March 09 went up 3.6%, starting from December the 7th, so you can sort of see the numbers on the right. We've got about 4 million more uninsured than we had as recently as December of 07, and about 4 million additional people covered by Medicaid. So who pays for employment-based coverage? Employers write the checks. They write the checks for a heavily disproportionate share of the total. You can see 84% of the individual's cost of coverage and almost 3/4 of the family cost of coverage is covered by employers in the checks that they write. And it's 20% of total spending on health care. But I think economists sort of across the political spectrum agree that it's actually employees that foot the bill. The overwhelming majority of the check that the employer writes is actually foregone wages for the employee. Okay, sort of see some quotes on that. The first is from a review. The second is from a recent piece in the Washington Post. The reason why people's wages stagnated is because that money that would otherwise have gone to raises was being sucked into healthcare premiums. So employers send it to the health insurance companies to buy healthcare coverage rather than paying it to the employees. And this is part of the consequence of linking employment and health insurance is there isn't the degree of transparency on where your wages are actually spent. So why does it matter? Well, the first important reason is it obscures the trade-offs that people are making between health insurance and wages. Okay. More money spent on health insurance is less money that's available for wages and raises and hiring new employees. The other difficulty is that lots of people engage in moralizing, blaming employers for not providing better coverage, and it encourages you to think about mandates as basically free because they're off-budget expenditures, when the truth of the matter is they're not true. Healthcare is expensive, health insurance is expensive. If you mandate employer-based coverage over and above what they're providing voluntarily, you have to expect a variety of adaptive responses, okay, including lower wages for the workers that receive them. And you may conclude that's a reasonable trade-off, but you shouldn't assume that someone somewhere is not going to foot the bill. The other difficulty, and I think the one that people don't tend to focus on, is if you mandate employer-based coverage, you're implicitly indexing the minimum wage to the healthcare inflation rate, okay? Because they have to then pay everybody, minimum wage employees as well as everybody else, both their compensation but also a health insurance package. And so the health insurance package part of the compensation scheme is going to increase, and that's going to increase the implicit minimum wage, and that's going to have implications on the cost of hiring new people at the bottom of the income spectrum. And at some point, people are going to say, I'm going to substitute away from hiring additional employees and think about alternative ways of structuring my business. And that all because it's not transparent. People don't think about the fact that that's a consequence of tying employment and health insurance together. Now you can sort of repackage the myth in a way that actually makes it more salient to people. So the conventional way in which this happens, and this is actually from an HHS report of about 3 weeks ago, is to observe that GM spends a lot of money on healthcare, and that's a crushing healthcare costs mean that it's difficult to compete in the global marketplace. Well, crushing healthcare costs are just part of compensation. So another way of framing this is high compensation makes it hard to compete in the global marketplace. That's true, but it doesn't necessarily imply anything one way or another about what you ought to do about the problem. And you shouldn't assume that changing how the healthcare system operates is going to do anything in particular about that. The wages are going to be the wages. That's the market rate. It's not driven off of the fact that the healthcare system in particular is making things worse. Let me now talk about the second myth of American healthcare, the 46 million. How do we figure out how many uninsured there are? Okay. Well, we do surveys. And there are actually a series of surveys that are done. They use different methodologies. They cover different populations. But even if you sort of ignore those things, you have to start by saying, how are we going to figure out what it means to be uninsured? And so what we have here are 3 different ways of asking the question. Were you without insurance for the entire past year? Are you uninsured today? Or were you uninsured at any point during the past year? Now, each of these are defensible measures of the uninsured. But which of the 3 you choose has a pretty significant impact on how many uninsured people there actually are. Okay? And not surprisingly, the numbers are lowest in the first bullet and go up as you move to the second and the third. So let me actually show you sort of the very concrete exemplar of that. The 45 million comes from the current population survey. The question that it employs actually says, are you uninsured for the last full year? But you get an answer that looks a lot more like comparing it to the other surveys. Are you uninsured at the time of the survey, i.e. at a particular point during the year did you lack insurance? I'll come back to that. But let me instead point you to the 3 following rows, each of which, using the same population, asks each of those 3 questions. And so what you end up with is numbers at the bottom end is 30 million and the top end is 70 million. So how you ask the question has a profound impact on how many uninsured there actually are. And it doesn't imply that the cost of fixing the problem swings as much, because the way in which people score the cost isn't tied to how you ask the question, are you insured or not. But, and I'm not trying to say 30 million we shouldn't care, 68 million we should care a lot. The point that I want to make is the 45 million figure reflects a fairly obscure methodological decision, and unless you start to look behind the data, you don't realize how asking a question influences the number of people. I think the more significant point to take away from this, though, is irrespective of how many uninsured there are, they're not a homogeneous group. Okay? This is some work that was done for HHS by two different consulting shops, the Actuarial Research Corporation and the Urban Institute. And they use somewhat different methodology, which is why the numbers look a little different. But what they did was they took the figure for uninsured at the time, which was in spring 2004, and they tried to break up the uninsured into discrete groups to get a better handle on the degree of heterogeneity within the population of the uninsured. Now remember, the way in which we figure out whether people are uninsured or not is we ask them, are you without insurance? And it turns out, when you ask people, are you without insurance, some of them answer wrong. Okay? It turns out, depending upon which of the two studies you credit, between 10 and 20% of the people who said, I don't have insurance, were actually enrolled in Medicaid at the time. Okay? I think even more significantly, between 8 and 11% were not enrolled in Medicaid or S-CHIP, but qualified for the program. Okay, so they qualified for a subsidized program, but for whatever reason they weren't currently enrolled. That's a failure of outreach. That's not a failure of the presence or absence of an existing program. And the point, and I'll emphasize this later, to take away from that simple slice of the data is you ought to, the way in which you think about targeting solutions depends very much on how you identify the source of the problem. Okay? Third, from the top is people with income over 3 times the federal poverty level. This is conventionally used within the field as a measure of people's ability to afford insurance. Okay? Obviously, the federal poverty level varies depending upon where you live. So these are people who, by at least one measure, not necessarily a perfect measure, but one measure of affordability have decided not to obtain insurance. And so that population is obviously going to be somewhat different than the people who are eligible for a subsidized program and aren't enrolled. The next slice of the data is about 20% of the uninsured are non-citizens. Okay, a significant chunk of those, and the data is relatively squishy, are undocumented aliens. Okay, and that fact is completely irrelevant to some people and extremely significant to others. And just one example: the original Clinton Health Security Act explicitly excluded undocumented aliens. Okay. Childless adults 18 through 34 are 10 to 11.5%. Basically, these are younger and, as a group, at least healthier than the general population. Some of them, obviously, are what people in the field call the young immortals, the people who think nothing bad can happen to them, and so they're not going to be very keen to buy insurance unless you compel them to, even if you make it easy for them. And then the last group are the sort of remaining. They're not covered by any existing program. And so if you want to reach them, you're going to need to come up with a new program to do that. Okay? And you're going to probably, the basic, I think, takeaway point is, if you want to address the problem of the uninsured, you ought to start by understanding they're not homogeneous. Okay? And so different strategies are going to be appropriate for dealing with the people who are eligible for an existing program but aren't enrolled. Then for people who can afford to buy coverage but for one reason or another have not, versus childless adults who don't exceed 3 times the federal poverty level. They're just starting out in the workforce. They may not work for an employer that offers coverage. They may work for an employer that offers coverage, but they haven't gotten around to enrolling, or they've sort of made the calculation and decided they don't wish to actually pay the money for insurance because, given the choice between rent and insurance, they think it makes more sense to pay for rent. So the takeaway message is it's not homogeneous, and so you want to think about the policy to address them in light of that. The last point to again emphasize the non-homogeneity is that there's a difference between people who are without insurance for a short amount of time and the long-term uninsured. Okay? So this is data that the Congressional Budget Office did, published in 2003. Just 45% of those who were without insurance in their sample were without insurance for less than 4 months, and 30%, this is 16 plus 13, were without insurance for a much longer period of time. So again, if you think the problem with the uninsured is either they all lack insurance for an extended period of time, or they all just are without it for a short amount of time and then get it, you're missing the reality that it's actually a quite heterogeneous group. And again, thinking about different strategies in light of that heterogeneity might make some sense. Third, universal coverage means everybody will have access to high quality care. The point of this is not to say you shouldn't take seriously the problem of the uninsured and the universal coverage, but again to emphasize that we have problems on the delivery side of the market, and those problems need to be attended to as well. So coverage, just because people are covered doesn't mean they have access to care. Medicaid, I suspect for many of you in the room, is a sort of perpetual issue, the ability of Medicaid beneficiaries to access the healthcare system. So I put up Illinois because my own institution, the University of Illinois, announced about 2 weeks ago that it was going to close a center for women and families that serves 6,500 people in Pilsen, an area in Chicago. And the reason is that 80% of the population that it served was Medicaid, and the rates that they were receiving were basically not enough to keep their doors open, even though they were a public institution that were running a very sort of thin overhead operation. And if you prefer a more local anecdote, this is Diamante Driver. There was a Washington Post article about him about a year and a half ago, some people may have read. He lived in Prince George's County, was covered by Medicaid. He and his brother both had dental problems. And basically they couldn't find a dentist to take care of them because most of the dentists in Maryland were not willing to see Medicaid beneficiaries because the payment rates were too low. So all these people are covered by insurance, but they had a hard time accessing the healthcare system. Diamante Driver got an abscess, and because they couldn't find someone to pull the tooth out, the infection spread to his brain, and 6 weeks later he was dead. Okay, 12-year-old kid dead of cavities. Covered by insurance, a state insurance program. If you look, and 15% of the dentists in Maryland took Medicaid, and 30% of the kids on Medicaid had seen a dentist in the past year, but I don't want to pick on Maryland. The district and Virginia have basically comparably bad numbers on access to dental services. And you see this pattern over and over again if you look across states and you look across areas of the healthcare system. It's hard for Medicaid beneficiaries to find someone willing to take them, other than some clinics that basically specialize in Medicaid. And it's not just Medicaid. Okay? The people in the room, I expect, are pretty well insured. I'd be surprised if more than half of you have a primary care doctor. And if it was after 6 o'clock, you'll probably find it reasonably difficult to find someone to actually take care of you other than by going to an emergency room. In fact, the rise of retail clinics, so the clinics at Target and Walmart and so on, were because well-insured Americans couldn't get access to the healthcare system in the locations that it was available. And, if you doubt that, just get on a plane, go somewhere else, and then try and get into the healthcare system without going to the emergency room. Okay? The system's not set up in a way to provide access to people, even very well-insured people. The Massachusetts health reform obviously has dramatically increased the number of people that are covered, and the sort of immediate consequence was very substantial delays in obtaining access to the healthcare system. The New York Times has written a series of articles about long waiting lists to see a primary care doctor. And Massachusetts already has a very extensive healthcare system with lots more primary doctors per capita than any of the other states. We have a sort of nationwide problem with access to primary care services. There's very extensive literature. If you're in the healthcare system, there's a very extensive literature on the quality of care that people actually receive. It turns out the error rate's a lot higher than we might want it to be. So let me just point out one thing. Okay? How many people in the room when you travel on a plane carry your bag? Don't check your bag. Okay. Pretty high percentage of people. Okay. Most people are risk averse about giving the airline their bag and hoping that it will be there at the destination. The chance of the airline losing your bag is about half of the chance that you're being negligently injured if you're admitted to the hospital. Just think about that, right? You don't trust the airline with your bag, you trust the hospital with your life, and we see how the odds play out. Across the healthcare system, we're very good at very sophisticated high-tech medicine, but we're not so good at delivering it consistently. So if you're depressed, your chances of actually having it detected and treated appropriately are not very high. Your chances of receiving, you can sort of see these are defects per million, so being high is worse here on this figure. What are we good at? We're really good at giving people anesthesia. The chances of waking up from anesthesia are spectacularly high. Is your brain working every bit as well as it did before? Okay? And that's great, right? I mean, you don't want to kill people as a result of anesthesia. But that's not exhaustive of the things the healthcare system ought to be doing. There are pervasive quality problems, pervasive problems with consistency of delivery of services. So let me show you, this is some work done by people up in Dartmouth. And some of you may have seen presentations by the Congressional Budget Office that have incorporated some of this. The point of this is to show that geography is destiny in the healthcare that you receive. So your individual physician and the community in which they practice has a pretty profound impact on the actual care that you receive. Okay? So what they did was they took the 77 best U.S. hospitals as determined by that exemplar of sophistication U.S. News and World Report, who also decides which is the best law school in the United States. It's the University of Illinois. And what they did was they took all Medicare beneficiaries who had received care at those institutions during the last 6 months of their life. So at the end of the 6 months, everybody was dead. Differences in those inputs, by definition, couldn't have made a difference. And each of these dots represents one of those 77 institutions. And what you see is how many days you spend in the hospital seems to vary by quite a lot, right? If you go to Stanford, it's 10 days in the hospital in your last 6 months of life. If you're at NYU, it's almost 3 times that, okay? And there's some geography, right? It looks like the East Coast seems to keep people longer, and Cedars-Sinai on down. The West Coast seems to keep people in the hospital less time. Remember, at the end of this, everybody's dead, so none of it made a difference. But there's threefold variation in how long people stayed in the hospital, okay? But let's then zero in a little bit and say, well, how many of those days did you spend in the ICU during that last 6 months of life? And UCLA is up at the top, 9.2 days, okay? And Mount Sinai basically have flipped the results, right? So you'll spend longer in the hospital during the last 6 months of life if you go to the East Coast, but by and large, less of it's going to be in ICU. And remember, at the end of this, everybody's dead, so none of it made a difference. So what is this telling you? It tells you that there's very substantial variation. We're looking at basically threefold variation. This pattern is replicated over and over again if you look at the healthcare system. Where you receive your care profoundly affects what that care actually is. Let me show you one other one of these distributions. These are hospital referral regions now, which is basically a geographically contiguous area. I'll show you some more of that shortly. But what this is what's the likelihood for Medicare beneficiaries of receiving a procedure known as a TURP? That's a procedure for treating prostate cancer. The description is sufficiently unpleasant. I won't spoil your lunch, but this is not something people are lining up to get, by and large. And what do you see? Well, you see if you look across regions, each of these dots is an individual region, and this is the rate per 1,000 male enrollees of Medicare. And you see basically the same 3 to 5-fold variation in between the low and the high. There's a sort of nice, bulk of people between 12 and 14 per 1,000 male enrollees. But the thing that you discover, and the reason for the red highlights, is a couple of people at Dartmouth said, you know what we ought to do? We ought to figure out whether this sort of variation is because patients want different treatment or because doctors are practicing in this fashion. And so what they did was they went to this region here, which is the sort of red dot, and they started talking to people and telling them, look, these are the side effects of this treatment. These are the benefits of this treatment. You decide whether you want to receive the treatment or not. And what happened, even though they were well below the mean of locations, as soon as they started telling people what the consequences were of the procedure, they dropped down to the lowest level, basically, in the United States. So a lot of this variation is driven off of physician decisions. Physician decisions as to what they think is the optimal way of treating patients, okay? And not variations in patient preferences. So the fourth point, universal coverage will solve the cost problems of American healthcare. It won't, but don't take it from me. This is a quote from President Obama's press conference last month, and everybody can read it, right? You don't need to read it. Massachusetts also has opted for universal coverage with a sort of very innovative state plan, and they've now discovered that it turns out it's really expensive. You have to come up with a way to pay for it, even though the federal government gave them very sizable amounts of extra money, which obviously not every state can depend on that. They're struggling now with figuring out how to pay for the program without having to cut it back. And I think they're placing their hopes on a commission coming up with a new way of paying for healthcare services. We certainly need to come up with different ways of paying for healthcare services, but you know, basically, I'm not sure you should put all your chips on the hope that in the future we'll come up with a new way of paying for healthcare services as a way of avoiding the hard problem that you face with funding this. So let me, just a little bit more geography and cost problems. So this is Palo Alto, right here, and this is San Francisco, right here. They're both homes to very impressive medical centers, very high quality healthcare. If you live in Palo Alto, your chances of having back surgery are twice that of if you live 35 miles away in San Francisco. It doesn't get much closer or more similar than that. And so we have, again, this huge variation. If you live on the west coast of Florida, your chances of getting your knee replaced if you're a Medicare beneficiary in Fort Myers are a little more than 2 times that if you live over here on the east coast in Miami. But it isn't the case that some regions are high on everything and some regions are low on everything. You get a much more complicated pattern. This is a paper from Health Affairs. These are west coast of Florida. These are east coast of Florida. These are all normalized to be ratios relative to the U.S. average. And what you see is for knee, hip replacement, and back surgery, Miami actually has fewer of all of those things than basically anywhere else in Florida and than most other places in the United States. Whereas the west coast of Florida is higher, but not consistently, right? So this is knee, this is hip, and this is back. So Bradenton, much higher on back and much closer to the U.S. average on knee, and to a slightly lesser extent on hip. This is what people in the field call a surgical signature. The doctors in this particular area have gotten used to a particular way of practicing. They do more of some things and less of others. It isn't that they're just all churning all the time. And all of them believe that they're providing consistent, high-quality care to their patients. So not surprisingly, these sorts of variation in treatment have a huge impact on spending. And the Medicare program spends a lot of money, but how much it spends is profoundly affected by these variations. So this this is a map that shows by hospital referral division spending in individual parts of the country. Okay, these are 2006 data. So darker is more spending, and let me just show you a very concrete example of this. Okay, so this is Miami. Miami, the U.S. average for Medicare spending per hospital referral region is $8,300. If you live in Miami, the Medicare program spends $16,000 per Medicare beneficiary per year for your care. If you live in Minnesota, if you live in Minnesota, Medicare program spends $6,700, $10,000 per year per Medicare beneficiary difference. This is the source of the estimate that if we could just fly people from Miami to Minnesota to receive their health care, we'd save a lot of money. We could buy each of them a top-of-the-line, fully loaded Lexus, pay for their airfare, pay for their health care, and the Medicare program would still come out of that. And they, by the way, receive health care that had the same consequences. So what are we buying in these high-spending regions? Well, we're buying lots more visits to see the doctor. We're buying lots more hospital days. We're buying more people admitted to the ICU. We're not buying any more effective care. We do get more stuff, but it's not much in the way of actually improving the quality of care that people receive, or the outcomes for that matter. All right, so the last myth, and then we'll wrap up with plenty of time for questions, is that American healthcare is the 37th best in the world. Now, I've just spent a lot of time telling you all of the problems with American healthcare, but I don't want you to leave you with the impression that that tells you anything particularly useful about who's better and who's worse on the international level. So where does the 37th worst come from? Well, the World Health Organization did a study in 2000. They haven't repeated it since. When they issued it, they basically made clear that they thought that there were some methodological problems, which is why they've never repeated it. They used two scales. Overall attainment, which is how are you actually doing, and overall performance, which is how are you doing relative to how we think you should be doing given the amount of money that you're spending. And not surprisingly, that has a significant subjective element. That's the source of the figure that the U.S. has the 37th best, or 37th best healthcare system, 37th worst healthcare system. How did they score things? Well, they used a series of criteria, which, and you can see what those criteria are here. The difficulty with the measures is that most of them are not really measures of health system performance. Okay. Some of them are measures of health, although even that's somewhat problematic. So they use life expectancy as a measure of health. How long you live is a proxy, although not a great one, for population health. So you want to actually ask about, well, you're living, but how much disability do you have? The other difficulty with this is the implicit assumption that the healthcare system, differences in the healthcare system are responsible for differences in those measures. And the healthcare system can do all sorts of wonderful things, but it doesn't direct its attention by and large at actually health. It directs its attention at health care because of the way in which it compensates people. The only, I think, sort of good measure of health system performance is responsiveness, which is 12.5% of the total that they use. The other measures are basically measures of basically differences in the allocation of the costs of the healthcare system. Those are certainly things to worry about, but it's not obvious that they're important as a measure of health system performance, which is what this was supposed to be about. So there's a mismatch between the measures that are used and actually health system performance. And the other difficulty is the assumption that all of the differences that they find are attributable to health system performance or are best fixable through the health system. And again, I've just spent a lot of time telling you all of the problems with the delivery side, but it doesn't mean that you can do this sort of a measure and actually give it much weight. The other point to take away is look at who we're ranked with and at least ask yourself the question, would I hop on a plane to receive health care at a place that's higher ranked than the U.S.? And some of those places you might. In the interest of being diplomatic, I would not identify the places I would not get on a plane to go to, but I suspect most people in the audience would say, net, that's probably not where I would choose to receive healthcare services placed in the matter. The last point I want to make about this, which I think is something that often gets overlooked when we focus on other countries, is this is a Commonwealth Fund survey done by Harris. If you ask people in countries, what do you think of your healthcare system? Is it doing the job for you? And you break it down, the responses, into only minor changes needed, fundamental changes are needed, and rebuild completely. And then what I did, just to make it easy, is to add together the last two and come up with a measure of how many people are really unhappy with their healthcare system. The striking thing is that nobody's happy. Okay? Nobody's sort of ecstatic about their healthcare system, even in places that are held up as shining lights. The sort of lowest is the Netherlands, but almost 60% of the people are really unhappy even there. And each of these systems has their own way of financing healthcare and their own way of delivering healthcare, but the dominant finding is nobody really seems very keen on what they're doing, and everybody's looking for someone else to come up with a great solution. But at least if you view public surveys as a proxy for satisfaction, there doesn't seem to be, a single shining beacon out there. And then I juxtapose, just for the sake of making more fun of the WHO, the WHO ranking against people's the degree to which they're really unhappy. So, the Netherlands ranks very high, and the UK is next to them in the WHO ranking, but there's still 60 or 72% of the people who answer the survey who are really unhappy with the system. So that's a bit of a downer, but it at least suggests there isn't a single magic bullet out there that you can look to and adopt. So let me close with the Christmas card that Uwe Reinhardt, who's a Princeton economist, a very funny fellow, very sophisticated economist, sent out a couple of years ago to sort of make clear the challenges. Okay, so you open the Christmas card, and it gives you survey responses to a series of questions. And the first question is, should we have universal health care in the United States? And 85% of the people say yes. Okay, that's great news, right? Whose responsibility is that? Well, 75% of people think it's your responsibility. We agree whether that's great news or not, but nonetheless, a very substantial percentage of the American population thinks that it's the job of the federal government to ensure universal health care. And how would you finance this? Well, 65% of people in principle think that more taxes are a great way of financing the healthcare system. And then let's get concrete. Would you be willing to spend more than $50 a year in taxes to finance this? Okay, and let me just sort of flag, by way of comparison, the cost for a policy for a family of 4 in the employment-based coverage market is about $12,500. Okay, so you can sort of do the math on the mismatch between that and $50 more a year in taxes. Okay, now there's some other surveys that give somewhat more optimistic results, but it's very, very hard to get numbers much north of 40% of people who are willing to pay anywhere near close to the kinds of amounts of money that at least you sort of transparently present them the bill and ask them the question. In theory, they're wildly enthusiastic about universal coverage, but they lose a significant chunk of that as soon as they present it with the bill. And so I will close with the final line of Uwe Reinhardt's card. So I'm happy to take your questions. We've got time, but we're done well before the clock that I was told is the witching hour. Any questions?
Thank you very much, Dr. Hyman. Just a quick reminder, if you could fill out the surveys before you leave, that would be great. And also, for the Q&A, if you could wait for the mic if you want.
I'm also happy to answer questions about issues that go beyond the scope of what I covered here today. I write a lot about a variety of issues in health policy, so if you have more focused questions, I'm happy to take a crack.
Yeah, I've been reading a little bit about the lack of professionals in the healthcare system to actually deliver the care. So what do we do about the lack of doctors, nurses, etc.? Particularly if we're going to have universal care, would it be more? Do we assign people that you will become a nurse, you will become a doctor, or how do we do that? Or pay them more?
Yeah, that's a very important question that was in some ways implicated by the observations I made about Massachusetts and the difficulties they're having getting people into the healthcare system. I think we're going to have to think about what economists call de-skilling. Okay, that is increased reliance on paraprofessionals, on nurse assistants, physician assistants, on nurse practitioners who practice alone. I mean, the experience in retail clinics, at least, is that you can actually get broader access at a higher quality and at a lower price point. The degree to which you're going to allow them to practice unsupervised is something that I think is not necessarily a concern. But if you want to get access to a primary care system, you're either going to need to train a lot more primary care doctors in addition to people currently training, or you're going to need to basically make clear to people that you're not going to pay them their specialty rates, and you're going to pay more to the primary care docs and the market. Yeah, you
First that article about Malawi.
I'm sorry?
Malawi. At any rate, apparently they've got a real problem with the number of doctors per person, but they're solving it with healthcare workers per person.
Yeah, we've tended to basically say if you want medical treatment, you need a doctor, and use physician extenders, as they were somewhat pejoratively called, in very limited settings. I think, the kind of expansions that people are going to be talking about are going to place a lot of pressure on our existing delivery system. And, just to back up for a second, it's not like the ratio that we have between specialists and primary care docs came down from Mount Sinai and the Ten Commandments, right? It's the result of voluntary decisions by lots and lots of people, influenced by the ways in which we pay for healthcare services. So if you want a different output, you better change the inputs.
I think it was interesting how you looked at the different Palo Alto and San Francisco and Fort Myers and Miami. The thing that I would want to see is the demographics.
That's a great question, and the short answer is that, first of all, these are Medicare beneficiaries. Okay, that's the source of the data, this Medicare program. And second, you adjust for differences in the demographics. So if the age distribution is different in Miami than in Fort Myers, you have to adjust to compare across locations. So if there are more 75 to 80-year-olds in Miami than in Fort Myers, you have to adjust for that. You also have to adjust for gender, because the advantage of the Medicare data is everybody has the same insurance system, and so that's not going to drive differences in treatment patterns, for example. If it was two different insurance companies which paid two different amounts, you'd worry about that a lot. You're certainly right, you need to adjust for that. They've already adjusted for that, and they also express the differences in rates per 1,000 Medicare beneficiaries. So you've already adjusted for the number of people that were in each of those areas that could receive treatment.
And then also wealth and...
Well, Medicare, remember, doesn't, you can adjust for wealth if you want to. Medicare, because of the way in which its insurance system is set up, wealth differences don't drive the same degree of differential access among the Medicare population than it does in the general population.
Yes, I think one of the reasons for the high cost of U.S. medical care is that we provide so much assistance to the extreme elderly, maybe terminally ill. And I think in like the UK, they have a cost-benefit analysis. Wouldn't that save a lot of money if you had a cost-benefit analysis providing medical care to very elderly people?
So the Medicare program doesn't that's obviously the program that covers the sort of extreme elderly, end-of-life issues. Young people die as well, but the majority of the mortality is going to be concentrated among the Medicare population. I guess what I would say is the following, and this is, the broader literature I think bears this out. The problem is we do spend a significant chunk of money in the last 6 months of life. The problem is figuring out what's the last 6 months of life before it starts, right? People don't walk in with a flag that says, I'm going to die within the next 6 months, and so cut it off. And leaving aside the sort of people's willingness to volunteer for that treatment and the ways in which you could write rules to try and deal with it, it actually reflects a broader assessment within the Medicare program that we're not going to make those sorts of cost-benefit calculations as a coverage matter. Individual physicians in concert with individual patients can. But even, trying to make national coverage decisions for Medicare or the FDA's decisions on authorization, incorporating a cost-benefit analysis, I think, has been a very controversial issue. If you're looking for ways to save money on end-of-life care, I guess I'd just suggest to you squeezing out that regional variation is likely to be much more effective as an economic matter and much less controversial as a political and ethical matter than, say, as Governor Lamb some years ago said, you've got a duty to die, and why don't you just get on with it? Okay. So I think there's a technical challenge, which is figuring out what's the last 6 months of life, or the last 3 months, or the last month. And independent of that, there are, I think, serious ethical and political issues raised by trying to draw these sorts of requirements. But you're certainly right that centrally controlled systems make these decisions centrally, right? They say, we're not doing kidney dialysis on people who are over 70. Or we're not doing transplants of this sort on anybody. That's in the nature of running centralized decision.
One thing you didn't mention in terms of cost is the fact that a lot of people think if we could just prevent prevention of major end-of-life medical problems like diabetes, we would certainly save a lot of money. The fact that these other countries have these incredible preventive medicine medical systems, and we don't.
Okay, so a couple of observations. It's a great question, thank you. The first is we're world leaders in, among other things, obesity, right? So we're really good at that. And that has systemic consequences, including diabetes and various cardiac consequences, among other things. And some of that difference is not because of preventative care that's being delivered differently in different countries. It's because if you eat more, you get more likely to end up with obesity problems, or soda more, you can sort of more exercise less, whichever the cause of that is that you want to point the finger at. It's hard to basically say that those differences are attributable to differences in health systems. There are complex cultural issues and other things that are helping to drive that. The second point, though, is there's a pretty extensive literature on this. Preventative care results in better sort of quality of life for people. But the evidence that it saves money across the board actually is much less compelling. A relatively small subset of preventative care saves money across a lifetime. That's not a reason why you should or shouldn't do it. It's just you shouldn't expect it to be a magic solution to the problems. You should do it because it will result in higher quality of life for people, but not people. Everybody's going to die, right? So far we haven't come up with a solution for that. And so you're going to incur some of those expenses sooner or later. What you want to think about is what's the quality of life in the interim, and are we getting bang for the buck in investing in this? Okay, the difficulty I have with preventative care is It's sort of the mirror image of waste, fraud, and abuse, right? Waste, fraud, and abuse, if we could only cut it, we'd improve things. Preventative care, if we could only do more of it, we'd improve things. The problem is, with both of them, it's easier to say that than to actually do it. Please.
Yes, pretty loud. I just had a question regarding the, you had this big map on the difference in spending for Medicare. I've actually seen the CBO, which is the same map about the regional spending. And I mean, people have argued that one of the reasons for this regional spending problem is that Medicare operates on the fee-for-service system. And this doesn't...
It operates in the same fee-for-service service. I'm sorry, I shouldn't interrupt. Please finish your question.
And this doesn't provide any sort of incentive for people to actually spend less money. So how do you feel about tying Medicare instead of the fee-for-service to quality, like incentives for less surgery or lower hospital readmission rates?
So what you're talking about is what people now call value-based purchasing.
Right.
Right? And I actually wrote an article some years ago saying what we need to do is results-based compensation, RBCAs. And I watched that article sink without a trace. No one's ever cited it as far as I can tell. But the striking thing is the idea, at least, what people now call pay for performance, P4P. I basically lost the battle over the acronym, but now everybody's sort of talking the same game on this. And I think moving away from a we'll pay you whatever you do, whether the outcome is good, bad, or indifferent. And oh, by the way, we may pay you more if you do a bad job because then the patient will get readmitted and you'll have to be paid again to treat the problem that you created. I think it's not just intuitively obvious, it's the way most of the rest of the economy actually works, right? Is to provide mechanisms for people guaranteeing or bonding quality of services and tying compensation to the quality of those services. The only difficulty I have with the question is the same fee-for-service system operates nationwide. There are slight differences, more than slight differences in the percentage of the population on a state-by-state basis that is in Medicare managed care. But nonetheless, it's the same fee-for-service system in Miami with $16,000 per Medicare benefit year as in Minnesota with much lower. Okay, so the problem is compounded by the way in which we pay for health care, but it has other causes as well that you need to be attentive to. That would be my only sort of qualifier. I think there's one more question.
I have a couple of thoughts, but as far as like the employer-based care, why, can you kind of speak to the history of, why it's become so tough? I mean, we don't buy our car insurance through our employer, like, why is it so connected? And then also, in fact, I heard my boss talking about this morning, some of like the cash for services, like LASIK care, cosmetic surgery, things that aren't covered by insurance, the costs or the rates for those have pretty much stayed stagnant, or with inflation, or fallen over the years versus, hip replacement, might have skyrocketed, that sort of thing. Have there been any like studies on those market-driven aspects or services of that nature?
Okay, so I actually wrote an article about employment-based coverage some 8 or 9 years ago. It's called 2 Cheers for Employment-Based Health Insurance, and it's cited in the article that Chris is going to send hopefully everybody a link to. And the roots of the employment-based coverage system, I think, are very clear. Okay? It has everything to do with an accident of history plus federal tax policy. The accident of history was wage and price controls, which were implemented during World War II to try and deal with inflation, because basically a significant chunk of the workforce was off fighting the war, and so there was a bidding war for talent to fill the jobs that remained home. To try and deal with inflation, wage and price controls were imposed, but critically, the wage controls excluded fringe benefits. Okay, so if you can't pay people more in cash, you can give them more in benefits and you can give them more compensation. Again, remember, the employment-based coverage is paid for by the employee. This is the sort of flip side of that. The benefit is captured by the employee. So if I can't pay you more than I paid last year, but I can give you a really impressive health insurance policy. That's a way of increasing your compensation without running afoul of wage and price controls. So that was the accident of history with wage and price controls. The federal tax policy part of it was the decision by the IRS to exclude the value of those benefits from taxable income. Okay, and they reversed that decision in the 50s, and then Congress said, no, we like it the way that you had it, and enacted a statute that expressly excludes, amounts paid by the employer on behalf of the employee. And so the result is, there are a couple of results. The first is that if you get health insurance through your employer, it's cheaper than if you tried to buy it on your own, because you're buying it with pre-tax dollars rather than after-tax dollars. That's the first consequence. The second consequence is if your employer doesn't offer coverage, you can't get that subsidy, right? It's not like a tax credit that you can just fill in a form for having more health insurance. The third is because it's a deduction rather than a credit, effectively. You end up with the subsidy worth more to people who are in higher income tax brackets. Okay, so Bill Gates gets a higher benefit from health insurance through Microsoft in terms of the subsidy that he receives than a secretary does, which is what people in the field call an upside-down subsidy, worth the most to people who need it. Okay. And that would fuel the precipitous increase in the number of employers that provided coverage and the willingness of individuals to purchase it, to opt in to the employment-based coverage system. And if you look across sectors of the employment market, bigger employers much more likely to offer coverage, more likely to offer a choice of coverage. Smaller employers substantially less likely. Across regions of the country, you see differences as well. That has more to do with the mix of employers. So if you're an agricultural or retail, your chances of better offering coverage are actually very small. So that's the sort of very quickie version of a long and boring and heavily footnoted article that I wrote on the subject. The second question that you asked is, what do we know about things paid for by first-party coverage versus third-party coverage? I've seen some reports that suggest that the rates of inflation are dramatically lower. Not surprisingly, when people are footing the bill, this is in lots of ways the point of this as well. When people are footing the bill, they suddenly ask a different set of questions than when somebody else is footing the bill. And how you think about that, and how you think about the broader issue of how should we allocate the costs of health care coverage to people are going to be influenced by whether you think healthcare is what economists call American, that is, you want to be able to get access to it regardless of ability to pay, or if you think it's just a market commodity where your ability to pay ought to factor into it as well. There is, and I don't want to go on too long because I'm a professor, that's what I do, is go on too long, but there's a literature on how having to pay something for healthcare affects people's consumption decisions. I'm happy to stay and answer questions after if you want to go.